They usually save the best for last, but they asked me if we could talk about healthcare first today. So here I am. Quickly, my background, I was a Russian intelligence analyst by training. So я говорю по-русски язычно. I worked for the NSA. I share that with you so you know I am officially a nerd. And I love numbers, but I was a rare nerd. I like talking to people too. 70% or so of the people in Intel are introverted, so I didn't fit in that well, so they put me on the road. And I ended up traveling 9 months a year overseas, had a black passport, and they send people over here to see if we're destroying missiles. We send people over there. And it was a fun time, but I wanted to have a family, so I ended up getting out of that line of work and going to work for an insurance company. So like everyone else, I've been in insurance. I got into it by accident. And I saw pretty quickly we had a really good business model. We could deliver an increase, health insurance particularly. The rest of you in the other branches of insurance, I'm sure, operate much more ethically. But we had a great business model. We could deliver an increase every year, not tell our clients exactly why, and there was not much they could do about it. And when, if you think about the last 40 or 50 years, what's happened in healthcare since Medicare was put into place, it was 5% of our economy when it started. It's a fifth now. And if you look at the last 11 years with the ACA, we've got deductibles are up. This is our report card. Deductibles are up 87%. Premiums more than that. And we've got, the average American has $400 in their savings account, and they're facing that large deductible. So we've done a lot of cost shifting, and the only clear winners have been insurers whose stock prices are all up 350 to 500%, and large hospital systems. So we could do better. And that's a journey that I embarked on some time back, about 11 years ago. I did have a family. I've got an 11-year-old, 10-year-old, 7-year-old, 5-year-old, and 3-year-old. I do know what causes it, and I do have a TV. Yet I still keep having children, or my wife does anyway. So after working for an insurance company for a handful of years, I decided to become a consultant, work for employers, and see if we could figure out a better way to approach this inflationary area of our economy and spend. And COVID certainly has put a spotlight on what we do and what I do. I've had the chance to work with more than 2,000 employers in a 10-year time frame. Do some version of this talk about 40 times a week. And while insurance and healthcare doesn't sound that exciting necessarily, being part of fixing the way that we pay for it has been pretty exciting. And I look forward to sharing it with you and answering questions if you have some. My average minute, I told you I like numbers, I track everything. My average talk is 22 minutes, so I'll probably finish early. You're in luck. This won't last that long. So let's dig into it. Transparency really is the problem that we face. I'll give you a couple of examples. I was looking at an employer plan in Dallas a couple of weeks back. You could go, they had a Blue Cross Blue Shield plan. You could go in-network and get an MRI and pay your in-network copay. It was $100 on this particular plan. You could go to a handful of facilities, all within 25 miles of the headquarters of this employer. The plan would pay very different amounts. So those providers would bill the plan based on whatever their contract was with Blue Cross Blue Shield of Texas. What's going on behind the scenes, though, that most consumers are completely unaware of? Somehow, magically, we've trained our consumers to consume in terms of copays and deductibles, and we have completely hidden the actual cost of care, which has allowed some real crazy things to occur. We have great health care. The way we pay for it's pretty crazy. Here's an example. You could go in-network, and at the low-cost freestanding facility, the provider would charge the plan $700. The high-cost facility, which was built right outside the Cowboys practice facility, would charge the plan $7,000. So a tenfold increase, same exact procedure, same copay, completely invisible to the member. And so we've taken this powerful force, the U.S. consumer, and disabled that by design. And it's driving up cost incredibly. Another example I just saw in the media here recently, and somehow I did a media interview, and now I guess they thought I talked okay, so I'm doing them 3 or 4 or 5 times a week. And a hot topic right now, drugs. We're the only country that allows drug companies to advertise directly to consumers. And they tell us that the reason they need to charge our consumers so much more than they do in the rest of the world is to fund R&D. But here's another number for you. They spend 19 times more on advertising than R&D. So we've got a real issue there. Aduhelm, did anybody see a new drug for Alzheimer's got approved in the last week or so? Some of you forgot. You might get the prescription. Anyway, Aduhelm is a new drug, first in 18 years for Alzheimer's. And the FDA approved this drug here in the last week or so. Whenever they do this, they have a board of scientists that are supposed to tell them what they think and whether or not it's a good idea to approve a drug. So the board of 11 scientists, 10, they all voted. 10 said there's no evidence that it works. 1 says, I'm not sure. They approved it anyway. The drug costs $56,000 a year. It's an outpatient procedure. It will be an infusion therapy at your doctor's office. And the copay, according to the Kaiser Family Foundation, for a Medicare enrollee will be $11,500. The average Medicare enrollee's income is between $29,000 and $30,000, so 40-ish% of their income will go to a copay. When you factor in all the costs of that drug, the doctor's time and staff and facility, and the fact that a third of those in the trial that received the drug had brain bleeds, so they need to get regular MRIs while receiving the treatment, the actual cost will be in the range of $100,000 a year per person that we put into this treatment. We have 6 million people with Alzheimer's on Medicare. And we also, another little fly in the ointment is that a little known rule about how we create these incentives in our system is that each time a physician prescribes this drug, they receive $3,360 from Medicare. So raise your hand if you think a lot of prescriptions will occur. Yes. And I do this with my kids. Raise your hand if you like hot dogs. And then they raise their hand. Raise your hand if you like running around with no clothes on. Raise your hand. It's a pretty funny thing. You should try it. We did it on the BART system in San Francisco, and they just spontaneously did it with a full BART load of people, and it was a sight to see. In any case, the situation is that Medicare last year spent $90 billion on drugs in total. This one drug, if we have 500,000 out of the 6 million get prescribed, will cost $29 billion. And that's just for the $56,000 number. If you add in the rest of the ancillary costs, we're looking at $56 billion. It's going to hit Medicare Part B. The average Medicare Part B person pays $147.60, I think, for their premium monthly. What will happen to that? So it's approved, and they've given Biogen, the company that created this drug, 9 years to do a confirmatory trial to determine that it actually is effective. That's what we're up against. Is that incredible or what? And I could rattle these stories off to you all day, but I'm not supposed to just oppress people. So, transparency, that's our problem that we face. And the good news is we can fix it. I'm smart, I'm not so smart, I'm saying I fixed healthcare all on my own, but I've become a good student of people who had more weight in the industry. Tom Emmerich's a great example of this. He ran Walmart's benefits for about 15 years, and he was able to go to the vendors that I used to work for and say, look, this game where we give you a big pile of money every year and you give us less benefits and the pile gets bigger and the benefits get skinnier is not working well for us. This has climbed up the cost stack on our balance sheet, and it's the largest expense around which we have no visibility, and that does not lead to good results. And their average per employee per year profit was not like a Facebook at $400,000, it was $6,500. So if they allowed healthcare to look like it does on the screen right now, climb to $15,000 per employee per year, it would literally eliminate their profitability. So that's the state we're in right now. If you look around the country, if we take the number of employees that are on a plan, divide them into the total spend, we're at $15,000. When Obamacare started, we were at less than $5,000 per person, so a different metric than what you see on the screen for my numbers people. We're now north of 10, so it's doubled in about a decade. And that doesn't include all the cost shifting, the climbing of the deductible, where we've put, most people are paying for their own care, right? When they go in and their child breaks their leg, or if you have a 5-year-old like me who needs stitches every month or so, then you end up paying, they're paying for a lot of that care themselves. So it's up 30% in the last 5 years. That's inflationary. It's not working. There's some problems that we saw that we wanted to help fix, that we identified. One is there's lots of misaligned interests. I shared some with you today when talking about Adahelm, and there's lots more. We'll talk about a few of those. There's been a declining focus on managing the cost of claims. For others in the insurance industry in this room, your interests are more likely aligned with your client than ours in healthcare. When it comes to your auto insurance, as an example, your auto insurer does not want you to get into an accident. That is a loss. In health insurance, one of the unintended consequences of the ACA was that we told insurers they had to spend every 85 cents of every dollar that you paid them in premium, they had to spend on a claim. And they got to keep the remaining 15 cents. So the outcome was they do better if claim costs go up. And so we aligned their incentives with large hospital systems, and both have been really big winners as a result. Some of these hospital systems, community health systems, as an example, just posted their most profitable year in over 11 years while their beds were empty during COVID. Another really interesting story there. They sued patients, 18,000 patients who had bills that were outstanding, bills as small as $187. And those people mostly were unemployed as a result of COVID, and the cases went to court, and they were, as a technicality, they ruled in favor of the hospital system. So they took about $800 million in aid from the care, the rescue packages, and then they sued and got another $500 million. Another problem there. So there's been a declining focus on managing the cost of claims, and we'll talk about that. Then the third problem is that at time of renewal, commercial plans, if they're in the retail market, they do not have good options, kind of my little intro when I talk about giving an increase, not telling you why, and not giving you many options or ways to resolve it. That's what employers are facing. They either absorb the increase or they pass it on to their employees in terms of increased payroll deduction or increased out-of-pocket costs in the plan. So we've seen a massive cost shift. Traditional brokers essentially go to an employer every year and recommend an HSA or a high deductible plan and then move on down the road. So we need better options for employers. And we can get that by building dynamic health plans. That's what I'll share with you today. These are the goals we have when we build this. We want to work with an employer or a commercial plan, and convert some of this large operating expense to earnings. We want them to have more predictability. I just sat in the back of the room and I got an email from a consultant somewhere in Texas. They have a client that just got a renewal increase of 43% from United Healthcare. And at the same time, United Healthcare has posted their largest quarter-over-quarter profits, $6.6 billion versus $3.3 same quarter last year. Did very well from COVID. Claims were down 70%, and yet large increases are coming out in those retail settings to these employers. So we want more predictability. We sit down with employers when we build one of these plans, and we meet with them quarterly, and they know where every dollar in their plan went. And then we monitor them in real time, looking for opportunities to optimize what's going on because of what I described with the MRI. Every single thing in healthcare is subject to that kind of stuff going on behind the scenes. Recent example, we had a case where a dialysis patient showed up in a group, a rather small group for us, around 100 employees. That could be a $300,000 hit to a plan that's about $1 million plan. So pretty significant. We were able to source that at $100,000 and get the out-of-pocket costs waived for the member. So good for the plan, good for the member. And the provider was happy to do it. Better outcomes. I say we have great healthcare and the way we pay for it's crazy. Here's a few examples. There's an unexpected relationship between cost and quality in healthcare in our country and the way we pay for it. A-rated hospitals on average are 22% cheaper than D-rated hospitals. And who wouldn't want to go to an A-rated hospital? But the D's don't put a big D on their door saying, don't come in here. You could go to a center of excellence right now and get a total knee replacement for $16,000 by one of the best surgeons in America. And yet when we analyze the data inside of health plans, we'll see it billed at $140,000, as high as $270,000 by a less qualified surgeon all the time, and everywhere in between. And there again, it could be that situation, and oftentimes is, where that copay, deductible, max out-of-pocket, whatever the out-of-pocket risk is to that member, their costs are the same regardless of where they go. So we've disabled that good consumerism. We want less risk, and we want to align incentives. One of the biggest problems we face is that there's a misalignment of incentives. These are the 4 cost drivers in a plan today. There we go. Prescription drugs are running around 30%. Hospitals the same. Outpatient surgery, 20 each. I know you're out there thinking like I am, where's the other 3 points? We all have to pay for, something for Obamacare, some taxes and fees. And so that makes up the balance. I list drugs first because it's the fastest growing. It's quickly on track to be 50% of what we all spend on healthcare in the next 2 years. It is a looming storm cloud on the horizon, and it is, the Aduhelm example is one of many as to why it's out of control in the way it is. There is good news there. We can clean that up. I'll show you how in a second. Hospitals, same thing. I've mentioned they've been big winners. We can clean that up. Outpatient surgeries, same thing. We can clean that up. Primary care, we should all have a moment of silence for primary care, just a minute, as it is a dying industry. And we need to revive it, really, is the issue there. They're being bought up by hospital systems. Independent primary care doctors tell their children, don't go into this line of work. They're bought up by hospital systems, and then they put rules in place that require them to drive the patients as quickly as possible to specialties where real billing occurs. So that's a problem that we're facing for sure. So let's talk about drugs. Who likes drugs? Just kidding. It's legal, you can admit it. You did it when it was illegal too, you know that. So just teasing, but not really. So anyway, drugs. The real problem in our system, you've got a normal supply chain. You've got a manufacturer making a drug, a wholesaler, and then you've got a retail pharmacy where you go to get your prescriptions, right? Everybody goes, they get their prescription, bing, bang, boom. Then you've got a pharmacy benefit manager off to the side. The pharmacy benefit manager charges a fee to manage the formulary of the plan. So they get to say, yes, the drug goes on it's this copay, this level, whatever, right? They make up all these tiers, they put the drugs on. In business terms, what they do is control shelf space. They have a lot of power. They negotiate in secret with drug manufacturers and tell the drug manufacturers, if you want this drug on the formulary, this is how much you'll have to pay me. So what we see is, if you look at insulin as an example, Humalog is the most commonly prescribed insulin in America today. It's $550 a month. When someone in your plan goes and gets insulin, it's $550 a month for Humalog, Eli Lilly. And the whole supply chain is supported by 220 of that. The manufacturer, wholesaler, and pharmacy share 220. They're profitable sharing that. 330 now is hidden in all these buckets that you see, and it's waste. Pre-ACA, go back many years, these pharmacy benefit managers provided this service for a small fee. They made literally a few bucks each time a drug was dispensed. Now when you look at insulin, they account for 60% of the cost. And that is an extreme example, I admit. If this was a weight loss commercial, I'd have to say these results are not typical, blah, blah, blah. But you can take any other drug and sub it into that conversation. The good examples are 30% waste. So waste is 30 to 60% of what is soon to be 50%. If a bus leaves Chicago going this many miles an hour, I just gave you a good math problem there. So anyway, it's a big problem. How do we fix it? Fortunately, there are pharmacy benefit managers. As a result of this movement that I talked about, that Tom Emmerich, I think, is most responsible for starting with Walmart, there are pharmacy benefit managers now that are willing to operate with total transparency. We use them when we're building dynamic health plans. They do it the way that was done 15 years ago. They charge a per script fee, and what used to be $3 now costs $6. And when we make that simple switch, it is invisible to the members. They can go to the same pharmacy they're going to today, pick up the same drug they're picking up today, All that changes is the bin number on their card. And all of a sudden, your plan is paying $220 plus $6.50 for insulin, Humalog, instead of $550. Same drug, same place, eliminate the waste. When we do that, we see 30 to 50% of the cost of drugs go away, year one in a plan. So that's how we take care of drugs. Let's talk about hospitals. That's a big mess too. We've got this new transparency rule. Anybody see a new transparency rule that kicked in January 1 for hospitals? They had to publish their pricing. I'm a sick person. I read all the healthcare news, so I'll quickly catch you up on it. January 1, hospitals had to publish their pricing for 300 common procedures. And it revealed something that we've been taking advantage of on behalf of our clients for a long time. And that is, and by the way, it wasn't new. It was part of the original ACA, one of the few parts I really liked. And it just took somebody finally had the gumption to enforce the rule 11 years later. And against the wailing and gnashing of teeth of the hospital systems who fought it in court. So here's what it revealed. The average hospital has more than 150 prices for every procedure they perform. Raise your hand if that sounds crazy to you, or if you're just tired of sitting still. 150 prices for every procedure they perform. That's crazy. Why do you think they do that? I'll give you one hint. It's incredible. So I was looking at a plan, analyzing the data in a plan. This was in the middle of California somewhere, and we had a client there. Someone needed a heart procedure. They could go to the same hospital, same surgeon, same OR, and depending upon the card that came out of the wallet, that hospital would bill anywhere between $80,000 and $540,000 for that procedure. 80 and 540. That's a big difference. 11-year-old math can get right quick on that one. That is pretty crazy. What you see on the screen here, we can pull this on any hospital. It kind of indicates what we're up against. On the left column, this is the cost to run this particular facility. It's a California Bay Area hospital, for whatever that's worth. But they're about the same everywhere. $750 million to run the facility. They build out over $11 billion. So their cost to charge ratio is incredible. 5, 6, 7% is common. Just looked at one in Kentucky, of all places. It was a religious hospital, and theirs was 1.7%. So they were creaming this rural area. And there is good news there. We can take advantage of that. We can fix that. Here's how we can do it at a procedure level. LA Times did a great article on this. They called all around the country, and they said, what would you charge cash for a CT scan? The average answer was $287. Not $2,870, $287. And when they did the same poll, they called all around the country and said, what would you charge if I pulled out my fill-in-the-blank insurance card? The average answer was always north of $2,000. Incredible. So we access that same service, national contracting. Again, just like with the pharmacy benefit management example, we're accessing contracts with national vendors who agree to operate fairly. We want them to make a fair profit. But if the procedure is profitable at $287 for a cash payer, why should we pay 10 times that, right? So we get that service at $600, and when we do that, we waive the out-of-pocket costs for all the members in the plan. Same thing with labs. Same thing with lots of classes of drugs. When you can drive this much waste out of the system, that's how you get to better benefits for the members and fix a really huge chunk of our economy that's out of control. When you start to realize that 30, 40, 50% of it is hidden waste, it's actually an optimistic story if you can fix it. And you can get the political will going to do it. There, I think we have a challenge. Outpatient surgery is a more quick example. I told you I'd be short and all that. We're getting to the finish line. Outpatient surgeries, just as crazy as the rest of it. What I did here is I took the contracted rates for the retail insurers, the Blues, United, Cignas, Aetnas, Humanas, stacked them up next to each other. You could have the same surgeon in the same OR doing a total knee every 30 minutes, and depending on the card that came out of the wallet, which means who built that plan, how well managed is that plan, and some other factors, what contracting are they accessing, how well are they negotiating these things? 85% of procedures are scheduled. Why can't you negotiate? You can. We have a group of people, they'll call. Pre-authorization will come through for a total knee. They'll call the surgeon and say, how would you like to be promptly paid in 5 days and not have to chase a member for their deductible, which many of them don't end up paying their share. And you go, they turn into collections people and so on. Would you be willing to offer a discount for that? You know what they say every time? Yes. Or wait 5 months for an insurer to pay me? Sure, I'll take it now. Anyway, look at the total knee in the middle. That surgeon could be cranking out knees every 30 minutes, and it could get billed out at 141, 98, 42, 26, 19. In the last 6 months, it's fallen to 16,000. So this can work, and we are seeing really good results, optimistic results all around the country doing it. Accessing better contracting in a favorable way with the providers. Not short paying their invoice, but actually working with them to get fair contracting in place. Because a lot of that big number doesn't make it to them anyway. So, primary care as kind of a finish. This is what's happening to primary care. Primary care used to be a way to encourage health and guide people through healthy living, identify things early, prevention, and so on. And we've gotten to a point where our incentives are so out of line that we need some new solutions. And there are some coming up. We've got concierge medicine, we've got some other things, direct primary care and so on, where the payment model can allow them to do their job and they are not under pressure from other parts of the system that require them to hit certain quotas of sending people to specialties, etc. So there are good solutions there, and there's some positive news there. So, in summary, what do we need? Transparency. We don't have it now. We do not have a free market in the way that we pay for healthcare. That is our biggest problem. How do I know that it will work? Well, we're seeing it work in thousands of cases around the country, but everyone can see it right in front of us. Think about cosmetic surgery. Think about other elective surgeries that aren't cosmetic, if it makes you feel better. I had an elective surgery, and somehow I feel obligated to tell you it was not cosmetic. I've always looked this good, or bad. But I had to get an elective procedure, and related to if you can have kids or not, So I went and I had this procedure. I found the very best person in America that does it, and I flew to LA and I paid $10,000. Had it been deemed medically necessary and I paid for it through my insurance, it would have cost $50,000 in that ballpark area anyway. So it works. When the way we've structured our insurance today is as the payer, without transparency, when that's put off to the side and you see free market forces in action through these elective procedures, the providers compete on cost and quality, and we get very good results. And the second thing we have to do, one of the most important things will be getting common sense rules around what pharmacy benefit managers are allowed to do and transparency around what they are doing today. It's when you look at 60% of the cost of insulin being waste, and then when you ask why, and they tell you it's for R&D, but pharmacy benefit managers do not engage in research because they don't manufacture anything, you really have to question that. And then the third thing is really reviving primary care. If we're going to fix the problem overall, people need someone that they can actually talk to that can help guide them through the system. So, thank you for your time. You've survived. You made it to the finish line and heard about healthcare today. Hopefully some optimism, not just depressing information, and hopefully some new information. They asked me if I would leave a few minutes for Q&A, so if anybody has questions, I'm happy to take them. Yeah, the smallest size is generally, it's amazing, actually. There's been such an evolution in what we're doing. We can work with employers much smaller than we used to. Now, just for profitability reasons, we might not, but we can go down to 25 people. We could go down to 10 people and make an impact. We tend to focus on the hardest hit part of the market, the part of the market that's overpaying the most, which would be those groups from 0 to 1,000 employees. We have groups as large as 30,000, but it's not normal. Yeah. There are states where it can be more difficult, less difficult. mostly because of regulations that were put in place by those states as a result of back-end deals with retail insurers to support their exchanges. California is a good example. They put pretty heavy restrictions on your ability to build a custom plan under 100 people. And that is because they wanted to force all of those small groups into one risk pool. And essentially the insurers said, we'll participate in your individual market where we're likely to lose if you force all the small employers to buy from us and give us some flexibility to recover our profits, recover our losses there. And it's led to really a high-priced result for employers in that state. But you can do it anywhere. These are ERISA-based. They're not state-based, but the states can regulate insurance. We end up building these plans on partially self-funded platforms, not because the funding arrangement in and of itself actually fixes the problem. It doesn't. You can have a self-funded health plan that pays $550 for insulin, or you can have a self-funded plan that pays $226.50. So the secret is not in the funding arrangement, but so the states, these partially self-funded plans are not subject to state regulation except for the reinsurance, because the state's departments of insurance get to regulate insurance. So that's how they can restrict your ability to be creative. They can put requirements on that. Okay. Yes. Thank you. On the drugs, we look at each cost driver. When it comes to drugs, so the question is, how do you do it, basically? How do we get these results? How do we get there? With the drugs, it's pretty clean and easy. We simply fire the pharmacy benefit manager that adds waste and hire one that doesn't. And then we also go a step beyond that and source specialty drugs more directly. We'll see how long that runway lasts. Most people, 85% of people actually qualify to get the drug from the manufacturer at a reduced rate or no cost at all. That's part of the rules that they had to agree to, the drug companies, was that they would make that possible if our system allowed them to charge tens of thousands a month for a drug. So they would have to make a pathway there, and the reality is most people actually qualify for that. So we can build the plans to accommodate that as well. So that's how we do it with the drugs. When it comes to facility charges, those hospitals have 150 prices. That means they have lots of different contracts already in place. So we oftentimes are accessing better contracting in that example. Or we are working with a network that allows us to take the case management in-house, where and 85% of procedures are scheduled, so when you have a pre-authorization that comes in on that plan for someone to get a procedure that's scheduled, then you can, if you're handling case management or an organization that you've hired whose interests are aligned with yours, high quality, low cost care, they can reach out to that provider or facility and negotiate in advance of that procedure and get better terms. And that happens all the time and every day. And we do the same thing with the outpatient surgeries. Lots of surgeons have facilities, they're freestanding surgery centers that they have ownership in, and they love working with us because they get paid in full, cash, boom, in their account in 5 days. Bundled, including post-surgical care and so on, they're going to get paid. And they know they're going to get paid now, and they're not going to get strung out, and they're not going to chase anybody for a deductible. So it's just creating better payment terms in that case. Yes? Yeah, we don't have to aggregate lives. I mean, they're pooled in the retail setting. These groups are all pooled, which is a form of its own reinsurance. If they're with the Blues, United, Cigna's, Aetna's, Humana's, we can build these plans on any of those networks. So we'll rent the networks, buy our own reinsurance, and that's its own form of pooling as well. We're not technically aggregating them. We're not putting them necessarily all into a captive or into another larger group like that. We don't really have to get the results. Any other? Yes, we do. We do. Sometimes for the very small employers that can be useful. Oftentimes what I see over time is the very good performers leave and then the bad ones stay and the captive becomes not so attractive. So you have to monitor that. Anything else? I think I'm going to get an A on my timing because it's exactly 10. Very nice. I enjoyed it. I hope you did as well. Have a great day.